All right. Okay. Welcome today. Thank you for coming, and I'm honored to be here with you guys. Talk about some adhesive dentistry. My name is Reuben, and I'm the professor and chair in UCLA in section of restorative dentistry. I've been teaching there for the past 20 years, and yeah, it's been fun. I've never been outside, so I hope this session is going to be two-way street because you guys can tell me about outside practice that I've been always wanted to go, but I'm stuck with the school for the past 20 years, and most likely I'll be stuck in the school until I die. Okay, I have no relevant financial relationship, so whatever I say, I have no string attached. I really hope that I have some kind of conflict of interest, but sometime before I die. Okay, so today we're going to talk about shear bond strength exercise. We just did it. We're just going to go over and review what that means. And then we're going to talk about adhesive dentistry in basic understanding, how well you are, is kind of fundamentals. And then we're going to discuss about bonding to the tooth, and then bonding to indirect restoration, including glass-based ceramics and zirconias. Okay? How many of you are doing bonding procedures every day? Pretty much like, right? Composite filling is bonding. Crown delivery is also bonding. So I think it's important that we kind of understand what we're doing. It is complicated. I myself cannot fully understand everything. And every year there's new things coming out. And that just new thing came out. It's called long chain silane, and it's the industry with this bonding has been changed dramatically. Okay, so we'll briefly talk about how we bond glass-based ceramics, how we bond zirconia ceramics, and then how we can optimize these procedures. Okay, how good you are at bonding? So we went through this, right? I know it was a little bit confusing, but this technique is for the 4th generation, which includes every single step: etch, prime, and bond, and then composite, right? And then actually, yeah. So this is actually I just did it yesterday, and this one is for OptiBond, and this is for the adhesive. Which one is that? The Auburn U, okay? I think I went up to 20 something. Oh. Yeah, 20, 22, something like that, right? And then this was Auburn U, okay? So I started with 3.6, so we can subtract 3.6 from the actual number. But I think that went up to above 20. So what does that mean? What does this number mean? You guys were, as a group, we had about 9.8, maybe like 11 or something with 14, the latest one. Clinically acceptable is about 20 megapascal, okay? So you really have to improve your, there's a room to improve in the bonding, okay? Yeah, this one goes to 27.8, 28. So subtract like 4, 24. So that's okay, all right? So this was OptiBond FL, which I did etch, prime, bond, and composite. This is Auburn U. I didn't etch. I just put the Auburn U and then put the composite. Okay, so the reason I want to do this, by the way, who's using 4th generation in your practice? 4th generation, etch, prime, bond. Okay. Who's using 7th or universal, which is just one step? Okay. Who doesn't use any bond? Okay, that's fine. Yeah, so I know I was very skeptical about using Auburn U, but recently what happened was, so this is what we did recently in our UCLA dental lab. I actually about 5-6 years ago, I went through all the data of how students did their kind of redo cases. So we went over redo cases for the past 5 years. That was 5 years ago, right? And then number one redo case is what? Composite. Yeah. Class 5, it falls out here and there. And class 2, okay? And that was number one reason for redo cases. You know, if you have redo cases in your practice, it hurts, right? Because not only the money, but the time. So you gotta minimize those redo cases, especially like composite. So what we actually did, we actually did the Optibond FL. I didn't use Auburn U, but we used a Scotch Bond, and that's another universal. And if you can look at this, they're actually better. You know, to be honest, I don't really trust this, but because Optibond FL is the kind of golden standard for bonding. Okay, so the most research was done with the Optibond FL. Well, it can be more, but look at this standard deviation. It's kind of narrow. That means this was done by one person who did the bonding research for many years. Okay, look at the standard deviation. That means one day you're all the way down here, right? This one day your window or the standard deviation, the window is very narrow. So you can have more predictable and reproducible bonding with the universal. You see what I mean? It makes sense because if you do 3 steps, it creates more room to make mistake, right? And you know the 3-step is kind of hard because you have to control the collagen. You don't want to completely dry the collagen, and like you gotta be moisture looking, but who knows what, right? So if you really want to look for the reproducibility and predictability in your practice, I suggest go with Scotch Bond or Auburn Universal, one step, and you save a lot of time. Okay, I know some of you are still skeptical about that, but we'll talk more about it, right? So let's kind of go into some basic understanding of the bonding. So let me ask you, when you do bonding, what are you bonding what to what? Yeah? Composite to tooth structure? Yeah, composite to, exactly. How about if you have like indirect restorations?
So indirect restoration to the cement and cement to the...
Absolutely, absolutely. See, you have dentin enamel indirect, and you're actually bonding all this to resin cement. Okay? You're not bonding restoration to the tooth. There's a mediator in between, which is the resin cement. So when you actually look at it, you gotta look at the different perspective. Resin cement to dentin, you have to think about that. And resin cement to enamel, you have to think about that. And resin cement to restorations. Okay? And you need to have this magic bullet that can bind all this very well. Okay? And it's complicated. It's not that easy, right? So when you're actually working on this bonding procedure, you have to think like separately. Is this adhesive that I'm using, it can bind to the tooth very well? Is it binds to enamel very well? Or dentin very well? And at the same time, to the restoration that you're doing. Okay? So there are 3 important requirements that you really have to think when you're into the bonding. Of course, first one is a micromechanical bonding. It's a surface roughening. Okay? Anything we do in dentistry, like etchant, whatever you see etchant, acid, we're roughening the surface. Okay? That increase micromechanical bonding. Actually, I don't like to call it bonding. It's actually binding. Micromechanical binding, not the bonding. Okay? But then just to be consistent with the other terminology, I'll go with the bonding. And how we do it, we can do the aluminum oxide treatment, like a sandblasting, right? Or phosphoric acid, 37%, we do that to the tooth. Or hydrofluoric and that's the one we do to the glass materials, kind of like that. And second thing is chemical bonding, okay? And that is very, very important, but a lot of people don't really fully understand. We all understand about micromechanical bonding, but the chemical bonding is something that was kind of overlooked. Okay? We'll talk about that. And then another important aspect of it is hydrophobic substrate surface, okay? Because indirect restoration, depending on what you are using, it could be hydrophobic or hydrophilic, but resin cement obviously is hydrophobic, right? Enamel is hydrophilic. Enamel is, in a sense, hydrophobic, but depending on how you treat the surface, it will become hydrophilic. Okay, if you roughen the surface, it's going to be hydrophilic anytime. Okay. So why do we need hydrophobic substrate surfaces? Because again, resin cement is hydrophobic. Your BCMA, Tecdima has a long carbon chain, and at the end of it, they have a carboxylic acid group that cause this polymerization. Okay, so they're very hydrophobic. Okay, so whatever you do to the tooth before you binding onto something, or whatever you do to the indirect restoration surface, you need to make them hydrophobic. All right, and we're gonna see how we can do it. Okay, this is not history class, but I think it's sometimes good to know how things got evolved. So I'm gonna briefly go over that. Enamel etching happened in I'm sorry about the small, I thought it has a long screen, so it's kind of narrow. Anyways, so the enamel etching happened in 1950s, okay? People thought about etching the tooth in early 1950s. I think that's a brilliant, that really transformed our dentistry. And then about 1980s, people start thinking about etching the dentin too. The dentin is more organic, right? It has all the dentinal tubules, dentinal processes. So it's more like organic area. So people thought that you don't want to etch the dentin because it's going to hurt the tooth. And they thought that will cause sensitivity issue. It's true, but it's not really true, right? And then 1982, they start talking about hybrid layer, resin tag into all these tubules, right? Now these are all the micromechanical binding, okay, observation. Chemically, there's a thing called GPDM trying to kind of bind onto this tooth now, and they will organophosphates. They chemically bind to like a calcium, okay. And then later on, the HEMA came up. HEMA has two arms: hydrophilic arm, hydrophobic arm, and hydrophilic arm goes into the resin tag and then attached to the collagen, and the hydrophobic arm is attached to adhesive, right? And any primers include HEMA, okay? And then, in early 2000, the thing called 10 NDP, that's the one I think that kind of transformed the dentistry. Okay, the universal adhesive is based on this MDP because this adhesive is acidic, okay? Meaning that they can etch at the same time, right? So after this HEMA concept, the total etch concept came up, and then after this MDP, the self-etch concept came up. All right? So you see, the first, second, third generation is based on these old materials. So we typically don't talk about first, second, third generation. I'm pretty sure you heard a lot about fourth generation because that's pretty much the kind of Bible of the dentistry. Okay. So it's a total etch 3-step. Again, etch, prime, and bond. Okay. And then if you combine prime and bond, prime and adhesive, that's fifth generation. You still use etchant, but you combine these two. So so again, like we're trying to decrease a step. We're so lazy, right? And time is money. So we're trying to decrease all these steps, and that's where it came in, right? And then they say, oh, we have this MDP, we can self-etch it and see what happened. And indeed, it was able to etch the surface. And that's the 6th generation, and then 7th generation, and then universal. Okay? So what's so secret about this TEM NDP? Okay? So here, I mean, this is kind of, you can see how each company trying to develop their product following these different generations. Okay? And now you will see a lot of universals. Okay? Again, like how many people are using universal right now? Can I have count? 1, 2, 3, 4, 5. Okay. How many of you are not using universal? Like still use the fourth generation. Okay. You know, they're all good. They're all good. Okay. I'm not saying one is better than the other, but I think personal opinion is that universal is better because it reduces your chance of getting mistake. Okay. Anytime, like I know you guys do all the surgery, the more time it takes, the worse the outcome. Like pain hurts more. So what you really need to do is go in and out and do fast, and that's good. And I think that's why all these companies are investing tremendous amount of money to develop to have universal, which is understood. And we gotta utilize it, right? So I'm gonna kind of compare 4th and universal because that's the one that we did today. I realized you guys didn't do much about Optibone FL, which, you know, this setup is still here until the end of the day. So any break time, if you wanted to optimize your bonding technique, you're more than welcome to use, or let me use it for you. Just set it up, and then you can come and I can always do it, okay? So 1st generation, when you etch it, you're roughing the surface, right? And then you put the primer, and the primer goes into the dentition tubule, infiltrated, and then they cause a resin tag. And then adhesive that connects the hybrid layer, right? And then you have composite. Now universal, you don't need to do all that. Okay. Can you imagine how much time you can save, right? And then do the composite, right? So in a sense, these are all in one step, right? And that's because of 10 NDP. Okay. So what is 10 NDP monomer? So if you look at the actual chemical structure, you have a phosphate group, which is hydrophilic, and this is where it's become acidic, okay? And then in the middle, you have a long carbon chain. You guys all took the OChem to get into dental school, right? So carbon chain is hydrophobic, obviously, and then you have a polymerizable group, carboxylic acid group. They can do the polymerization cross-linking, right? So their role is acidic. They can etch the surface, and that's the beauty of 10 MDP, okay? And they can chemically bind to calcium, zirconia, or metal oxide, okay? And that's the beauty of MDP. And lastly, when it cures, it gets solidified, they do become hydrophobic. So you're kind of preparing all this in one step to receive this composite, hydrophobic composite, whether it's composite or resin cement. Okay, so now we do a total etch, and we talk about when you use this universal, they recommend to use self-etch because they do etch the surface. But yes.
Doctor, for the self-etching is enough for the enamel because we used to say like selective etching also.
Yes, I'll get into that. I'll get into that. Yes, yes, I'll definitely get into that. So again, total etch means you totally etch the whole thing, right? And then you use the 4th and 5th generation, use that technique. Self-etch, the etchant is literally disappear, and the primer or adhesive itself has capacity to etch because they have acidic monomer, right? So with that in background, let's kind of get into a little bit more about enamel and dentin etchant bonding, and I think we'll get back to that. All right, so going back to the same slide. So there's actually another thing, the selective etch, okay? So total etch, you etch the whole thing, totally etch, right? Select, you selectively etch. And self-etch means, in a sense, no etch, right? But then your primer or thing will etch. So we call it self-etch. So wow, I already asked the question. Okay. So we kind of need to understand what we're trying to achieve by etching the surface, okay? So for enamel, you just wanted to provide micro porosity of the structure, okay? We're going to get into some SEM figure, photos later. So is selective dissolution of prism cores peripherally into which resin can flow and polymerize, okay? Now, dentin is to remove smear layers, get rid of all the things that clogged up, and then demineralize the dentin surface. And again, it will create micro porosities. Okay? So another way of saying this, it roughens the surface. Okay? You just roughen the surface. Now, etching is pretty acidic. It dissolves the mineral like hydroxyapatite. So that's why the calcium gets released, and you see the collagen sort of matrix in dentin. Right? Create microporosities, allow for creating high energy hydrophilic surfaces. So when surface is hydrophilic, they have more energy. So when you put water, they're able to disperse the water. So instead of creating like round, they just disperse, right? And so we want to make it hydrophobic surface. So as you can see, universal, you have a different pH. As you know, their pH is acidic, low enough, but not as high as phosphoric acid. Okay? So exactly, one of the person you just asked me that question, and this is exactly why we need to do selective etch, okay? Because it's not strong enough. So look at this. Like this is SEM, the cut enamel. The prismatic is that when you prepare the enamel surface, then you will see a fresh enamel, okay? And if you treat the phosphoric acid on there, you will see this kind of a beautiful kind of invagination of the surface, roughening the surface, right? Now, if you have different self-etch, it cannot etch as well, okay? So if you put like a bonding here like this, it's not going to bind. It hasn't created micro porosities, right? Now, it's even worse in uncut enamel. If you don't cut, like for example, your margin area, you didn't touch, right? And if you do phosphoric acid for 15 seconds, believe it or not, it doesn't get etched fully. So if you're doing ortho and try to put the wire band like a bracket and stuff, you wanted to increase the etching time to like 30 seconds. And it'll help make this kind of microporosity better, right? So you have to look at the uncut enamel and cut enamel differently, right? So depending on that, and sclerotic dentin too. The dentin that has been sclerotic, you want to leave etchant a little bit longer, not conventionally 15 seconds, all right? So a little bit longer, like I would say 30 seconds. Don't go over 9 seconds because you're going to damage the prism and all these microstructures. Okay? So the bottom line is self-etch adhesives do not work well in enamel. So in a sense, I never use self-etch mode. Okay? And that's because of that reason. Dentin etching, I mean, we all understand, we heard this like plenty of time from the dental school, so I'm going to just skip it, but then, well, might as well review. We always have smear layer, right? When you cut and things get clogged up, and using etchant, it opens up, but at the same time, the collagen matrices can collapse if you over dry. Okay? And then onto that, you put the primer that kind of penetrate into the tubule and fill in all these collagen matrices. And then on top of that, you put adhesive. And then now the surface is hydrophobic, and you put composite, it binds. So if you look at the SEM, you really can see a different layers of what you're doing. I mean, you don't see this, but it is actually happening. Okay, so whenever you do this bonding, you really have to imagine this. okay, what am I doing? I'm pushing this primer into this tubule. Okay? So if you just put it on it, it won't go in. What you really need to do is vigorously like rub it. Vigorously rub it. And not like a couple seconds, like 10 seconds. Okay? Only then they get into these tubules. Okay? So when you do exercise just today, if you just put it and kind of rub it like 2 seconds, it won't work. That's why I see like 4 megapascal, 2 megapascal. What you really have to do is kind of rub it. Rub it to the point where your microbrush kind of bends a little bit. And sometimes your prep is so small that your microbrush doesn't get in. And there's an even smaller microbrush. You should buy it. You need that in your practice. Because if it's so small and the microbrush doesn't get in, get that microbrush and scrub it. Rub it, right? And only then you are making this hybrid layer. Okay? So the problem is important to keep it somewhat moist. That's the key. I mean, like, I don't know what that means, right? And personally, I'd rather be a little bit like dry than like wet, because if it's wet, it's not going to bind anyway, right? I'd rather compromise a little bit of collapsing of the collagen matrix than the full of water that HEMA kind of dilutes up and cannot get in, right? But to be honest, like, who knows what, all right? So that's why I think the universal is a good option to do it.
Doctor, when we apply the bonding, we usually blow and remove the excess of the bonding.
Yeah.
But I see like sometimes some doctor will kind of blow like really hard and just remove all. Sometimes we'll go really gently.
Yeah.
And luckily in the specification, because I argued that one with one of my friends, and like he's just the guy that who blows hard. I'm a guy like who blows really gently because I already says blow gently. But there are some more prescriptions that say like just blow, just remove the excess. So
Yeah, you never blow hard. Yeah, if you blow hard, you're just eliminating this whole thing right here. Yeah. So never blow hard. Sometimes that's why when I blow the air, I have my assistant to stop turning off the high vac system because I cannot hear how much I'm doing, right? So I literally have to hear how much of the pressure I'm giving. But if high vac is right next to it, I can't hear. You know what I mean? So you really have to do really well blowing air. That's another key aspect in this exercise. Okay, you do want to see the film. Okay, you're just evaporating solvent like alcohol or acetone. Okay, you want other stuff to stay there. So if you blow hard, you will get 4. Yeah, or 2. Yes, you have a question? Yeah.
So when is a good time to stop like blowing the air? Because my understanding is like you do it until like the bonding starts like spreading.
Yeah. So you will still see the bonding, but then the things get evaporated, so they're kind of settle down, and that's where you wanted to do it. And to be honest, I do primer a couple times. Yeah. In fact, Auburn U, they recommend to do 3 times, 2 or 3 times, and in fact, Auburn U is acidic monomer, right? So you have to give them time to acidify the surface, etch the surface. 10 seconds is not enough to etch the surface. I give 20 seconds at least. And do a couple times, and that gives you enough time to, not only infiltrate into the resin tag, those tubules, but also give them time to etch the surface. Yeah.
After you do the filling, and when you take an X-ray, sometimes you have some kind of a dark line between the tooth and the filling material. So I was wondering, because that is because of the layer of the bonding is too thick. And I saw the 3M Universal came out with the Universal Plus, Ultimate Plus, whatever, with the already opaque the bonding agent. So what do you think, like? Because it doesn't happen always. Sometimes, when you do the filling, you have some kind of dark line between the tooth and the filling material.
Yeah.
Sometimes you don't. So I was wondering, how much should I mean, is that related to the bonding material?
Yeah,
Or
I think if you see some line, I think there's some gap. That's a gap.
That's a good.
Yeah, I think so. Because, bonding thickness is like 10 micron, like 15 micron, right? So the crown margin, if it's really good, it's like 20, 30 microns. And if you look at that in the X-ray, it's really closed, right? So I don't think that the thickness of the adhesives can be observed through the X-ray. Yeah. So if you see the line, I think that's the gap. Yeah.
So when you do the traditional one where you edge,
Mhm.
you can really see, you would be like, if it's chalky white, then that's how it should be. But when you do the universal, the self-edging, what do you do? Do you follow the manufacturer, like?
Okay. So chalky white is only happens in enamel.
Yeah.
Okay. In dentin, you don't really see the chalky white stuff, right? So enamel chalky white is okay, right? Because they don't collapse. They're hydroxyapatites, right? It's the dentin that we wanted to leave somewhat moist because the collagen collapse, right? So that's why we use the fourth system. It's very tricky. That's why you see the large standard deviation, because sometimes you're good, sometimes you're not. And that person was a very, very experienced PhD, many papers with the bonding paper. That she did that test, one person, right? Still make that huge deviation. So for me, I'm fine with any bonding strength more than as long as it's more than 20 megapascal. Do I care about 25 versus 35? No. I rather care about reproducibility and predictability. So that's why UCLA, we actually changed our curriculum. We've been using fourth system all this time, but since 4 or 5 years ago, we still teach fourth system in the preclinical courses because they need to learn the concept. But in the clinic, we changed to universal. Yeah, and it changed a
What
lot.
is the best standard, like, when you're using universal?
What do you mean best standard?
Like as you said, rub it,
Yeah.
couple of times.
Yeah.
Is that like the best standard?
See, this is exactly why I brought this one up.
Okay.
Nobody knows. I'm sorry if you practice 40 years. I don't care. If you never have done this, you will never know if you're doing right bonding procedure or not, because you literally didn't test it, right? Because in clinic actually, micromechanical bonding matters a lot, okay? But longevity-wise, the chemical bonding matters more, okay? So when you put it in, it doesn't fall out. It's good, but then it will eventually fall out, and I'll talk about that later too. Yes.
So doctor, when applying the bonding, you said the manufacturer recommends 2-3 times applying bonding. So that means apply the bonding, kind of gently dry, light cure it, and then again
Yeah.
apply. That's
Oh no.
Or just apply.
Apply,
wait,
yeah,
then
and do it
apply
again, yeah, and then give final cure.
and then final cure.
Yeah.
Okay, because also like somewhere I read that is like when you light cure it, it appears some cracks, and you want to kind of reinforce it again the second layer, but after first cure. So is that really? I don't really think that.
Yeah, I personally I don't think that matters. I rather do 2-3 times and make sure all these resin techs established, and then cure. Then a couple micro crack here and there, try to fill that up. What's the point if the second application does not get into the resin tech, the dentition tubule, right? The key is to get them into the dentition tubule, right? So it's always better not to just rub it and then let it all good and then do it. Like Scotch bond is kind of thicker than all universal. And Scotch bond you don't have to do multiple times. R1 universal is thin, so kind of you do 2-3 times. When you cement, the thinner one is a little bit better because if you have a pooling of adhesive in the corner, it may prevent from seating, right? So I prefer using a little bit thin, but apply 2-3 times. I really like to play safe than jeopardize. Okay. Any questions? Just
Sorry, I mean, tell me if I'm wrong. Give me some correction if I'm wrong. As my understanding, for example, for a SE bond, they use a two-bottle system, and I heard that that's pretty good compared to the fourth generation bonding system. So when you do it, because like I said, that they recommended self-etching because the etching itself, etching the capability for the primer is kind of weak for the enamel. So you do the etching, but you don't do the denting because they remove the smear layer, then it's going to prevent to making a kind of a hybrid layer.
yes.
Then it will jeopardize the bonding capability of the SE bond. But when I look at the universal, because I was looking at the 3M universal, I didn't, because they didn't have that much research going. I mean, the paper, I couldn't find it that much, so I just followed their manuals. They were recommending 3 different methods. So total etching, selective etching, and no etching. They recommended all 3. They said that much different.
Yeah, so that's how company kind of sell their product. It's like ours is true universal.
That's right.
Ours thing can do everything. But if you really dig into it, there's always some catch in that claim. And I have some examples here that you can kind of look into that. But general, when you use universal, selective etch is the best way to go. It's one way to do it is etch, and selective etch means you etch only enamel, right? And you're etching the dentin with the self-etch etchant, but it's mild, so it decreases sensitivity issue because they don't really remove the tag, they remove the smear layer in the dentin tubules. So there are pros and cons, yeah. Okay. So for dentin etching with phosphoric acid, you can see these tubules and very nice. And this is another kind of side topic, but bonding to this area is stronger than this area. You know why? Because it interlocks better than here. Do you agree? These are tubules. So in fact, when you prep the tooth, bonding to the side of the tooth is stronger than bonding to the directly on the top. Okay? Just letting you know. And yeah, anyways. So self-etch, as you can see, you don't remove all the other tubule. The smear layer still exists. Okay? So it's actually binding onto those areas. So phosphoric acid opens all the tubules. Self-etch don't. So people say that causes less sensitivity, post-op sensitivity. One of the reasons why there's a kind of biomimetics and kind of like that is all related to this kind of thing. Anyway, so dentin etching, total etching is like 37%. This is another kind of review. MDP containing self-etching adhesives, they don't remove it completely. And over-dry is okay. Here, you don't want to do over-dry. So here, over-dry is totally fine because you're not you haven't removed the smear layer, all the smear layer. So it's still intact. So in a sense, I'm kind of safe to just blow, right? And they need to stay there anyway to make the adhesive layer, right? So that's another reason why universal is more easier to use. So based on this discussion, total etch, when you use fourth generation, I still use it. Selective etch, also known as hybrid etch, that's when you use for the universal. Okay, when you use the universal, do etch the enamel. Okay, Self-etch, non-echo-wounded, I never use that anymore. Well, I don't use that. Okay. Because just like you said, the self-etch etchant primers or adhesives, they don't have enough low pH to etch the surface. Okay. So take home message: universal system is as good as, if not better than, the fourth generation. So if you haven't tried it, go ahead and try it, and shorten your time. Like by all means, yeah, why not, right? Universal system increase your predictability and minimize technical errors in bonding. So use selective etch technique. So if you don't trust me, I have both systems here right now. Okay, if you have time, if you want to try it, go ahead and try it and experience yourself. That's why I brought this one.
Doctor, so one more question is, like, if I had the chance, I will do the same test, but with different curing lights also. That will
Oh,
make a
yeah.
difference?
Actually, I was about to put that section today, but I didn't. I can talk about it a little bit. I have a slide because light curing is so important. Let me ask you one question: how many of you in your practice there's an assistant cures your light, your composite? Assistant. So you do it your own? Wow, that's great. That's great. Because, we have this a mark system where it's a mannequin head with a kind of a sensor, and you can kind of do it. And I literally have tested. If you look around like this, your energy drops. If you tilt, energy drops. So some assistant, they go like this. Have you seen those? Never do that, because what you're trying to do is transfer energy to composite, to activate this, to generate free radical. Okay? And if you don't transfer enough energy to the composite, then it won't solidify. That's the whole concept of more than 2 millimeter, you cannot do it, or like deep in depth, you need to increase the time. That's what it means. You are increasing time to increase the energy transfer to the composite, so they can activate, right? So, if I have time, I can go over it, but we'll see. I'm like, guys, I gotta hurry up. Okay, so let's talk about bonding to indirect restorations. So we did talk about micromechanical and chemical bonding. If you look closely enough, by treating with like hydrofluoric acid or the sandblasting the surface, you're creating this roughness to the surface. So it kind of interlocks, right? But at the same time, if you're using this, you're improving this additional chemical bonding by treating silane or MDP containing primers, right? So it mediates bonding and creates hydrophobic surfaces. Okay? So when you're actually trying to prepare your indirect restoration surfaces, you need to think this way, right? You need to create roughness, and you need to make it hydrophobic surface. Like the ceramic classification is based on like microstructures are like glass base. It's 100% feldspathic. Glass-based crystalline fillers. If it's a low lucite in there, it's like that's another category. If high lucite, 50%, it's like an empress, right? And lithium disilicate. And then you have a crystalline-based that fill with the glass filler. And then you have a polycrystalline solid, like zirconia alumina, right? Now, based on bonding protocol, I kind of separated this in two different categories, because anything that has glass-based, has a silica in it, it demands different way of bonding it versus like alumina or zirconia. Okay, so we'll talk about this. First, we're going to talk about this glass-based crystal materials. Okay, so glass-based materials are etchable. Oh, that should be one word. Etchable, right? To create a roughened surface. So if you put like 4% hydrofluoric acid for 5 minutes, I think that's kind of long. But you see the SEM shows the very, very nice roughened surface. You have this resin kind of infiltrating in there, and it will never come out literally, right? If you over etch though, you see a lot of crystalline, right? So your microporosity is sort of blocked by this salt, insoluble salt, okay? So when I know many of you ask your lab to etch the lithium disilicate, but you have to look into it because sometimes they over etch, and if you over etch, all these crystalline insoluble hexafluorosilicate salts are just they're not bonding onto it; they're just blocking the way. So it will significantly decrease the bonding. Okay, so you got to remove it. And in your office, it's possible. If you put phosphoric acid and kind of without agitation, you can remove quite a bit of it. Okay, the salt. If you kind of agitate a lot, you can definitely remove, comparable to the non-over etched surface. So just look at your. I actually have some case that it was over etched, and I kind of did it at the picture. But you can really tell whether it's over etched or not. Okay, it's kind of chalky. This picture's not as good, but it's kind of chalky and white, right, and kind of grainy. Right? So if you ever have this, don't put it in. Okay, even whether you want to do luting agent or bonding agent, don't put it in. Just try to just use a phosphoric acid, kind of agitate for 1 minute. It will remove a lot of these unwanted materials. Okay, so let's talk about silane. Okay, and I think this is where the beauty of the bonding, chemical bonding comes in. So silane has this, the silane group, again, this is the polymer resorbable group and carbon chain and the silica group. And when you add acidic, when it's acidic, then it starts binding to, it becomes activated because silanol, right? And then you have this one water molecule comes out from the silane by condensation mechanism, meaning that the water molecule has to get removed in order to establish this bonding. Okay? That's why when you put silane, you need to dry it. You need to let water evaporate. Okay? If you leave it like that, the reaction does not get complete. It takes time though to do that. And silane chemically bonds onto the surface. Okay? So what happens is in the porcelain, you have the silane conjugated or bonded onto it, and then you have resin cement, typically like a bis GMA, and then there's a polymerization occur here. Then everything is chemically linked. Okay, and that's where the chemical bonding is. So like the two bottle system is kind of the one that I use because the silane can go bad. Okay, it can go bad. I'll tell you more. So the key point here is the silane gets activated under acidic condition. Okay, remember acidic condition because MDP is acidic. I'll get back to that later. Okay, so it gets activated under acidic condition, and water molecule needs to be removed. It's a condensation reaction to complete this reaction. Yeah. Now there's one bottle system. Gosh, I mean, how can you do that? How can you make that work? Because it gets activated and it gets unstable, as I show you here. If it's activated, it becomes silanol. But if you leave it too long like that, all the bunch of silanol together, what happens is they get clumped to each other. They bind to each other. Okay, and the water get condensated, and then it becomes whole polymer. So if you try to use that and to silanate to bind onto the silica, it won't because it's already just like they reacted, they finished their reaction. Okay, so the problem with the one bottle system is it's a pre-hydrolyzed, it's activated, right? But how do you keep it activated state? By increasing pH.
Doctor, one bottle system is like a fluorhydric acid and saline together?
No, saline and acid.
Saline
So
and
two
acid.
bottle system is one is saline, pure saline. The other one is literally acid and water.
What kind of acid on the two bottles?
Just the low pH, like hydrogen. Yeah.
Is that one bottle system is replacing the fluorhydric acid, or what's
No,
replacing one?
nothing with the fluor.
Fluorhydric acid is no matter what you have to do.
Yeah. So they got activated in order to they can keep activated for stated for like 30 minutes, 1 hour, 2 hours, couple like that. So once they got activated, they immediately increase the pH. So they don't create this polymer.
Because
So
my question is, if that saline is the same thing like the kind of
Two bottle?
saline that we use it in single, like a 3 bottle, like fluorhydric acid, saline, and actually that's two.
Yeah,
one
yeah,
dry,
yeah,
right,
yeah.
dry area.
yeah.
That one also can get bad. That saline can get bad over the time.
Well, so what they actually did is they increased pH. That's why it was able to keep it in one bottle,
Okay.
right? If it's in the one bottle with low pH, then this happens,
Okay.
right? But whatever you see in the one bottle system, the saline one bottle or one cartridge like that, their pH was increased. So they kept it unreactive. They're activated, but they're not reacting to each other, right? But to play safe, I like to use two bottle system because two bottle system because they have a shelf life, right? So if you really are into this bonding and all that, just get two bottle system, pure saline, okay? And I'll tell you later, MDP doesn't work. The saline does not like MDP. I'll get to actually next slide is that one. Okay, so some one bottle system, they claim they have a saline and NDP, okay? And they call, oh yeah, it's like universal. My primer can do, you can use it whenever, right? But if you look at the chemistry, it doesn't work that way. Because if saline gets activated, it becomes silanol, right? In very active state. But I told you, if it's acidic solution, they're going to polymerize. They're going to start reacting to each other. There are nothing to eat. They eat each other, in a sense, right? So with MDP and silane, MDP makes silane inactive. MDP still works, but not silane. Okay. So here's one study. Actually, the dental material. What they did was, they have silane. Okay. They lower the pH with the hydrogen chloride. Okay. They lower the pH, so they call to 2.7. So it is called silane hydrogen chloride. And then they combine MDP with silane. We call that SMDP, silane MDP. Okay. And they actually, when they do bonding test, they can do either etch the surface, like roughen it, or they can do very smooth surface. So if you remove the smooth surface, then you're only relying on chemical bonding. Get it? So any result from here is 100% from chemical bonding, not mechanical bonding. Okay? So when they did this, when over time, like 10 days, I told you it got polymerized, unstable. So they can't silinate it. So their bonding strength decreased by half. Okay? So their shelf life, when it's bonded together, MDP makes acetylene inactive. Right? So you don't want that silane acetylene is not working at all. Long-term storage of silane and MDP containing acidic solution is unstable. They start making polymer by themselves. Now, they also use different primers. Okay, these two, single bond U, clear field, universal bond, is actually they do have silane with MDP, and then the other one is silane free. There's no difference. Having silane or not, there's no difference, because these silane cannot do anything. Here, whether silane is contained or not, silane is inactive, so it doesn't do anything. So incorporate silane in universal, it has no effect. So when MDP and silane is together, you kind of have to say, oh, MDP is fine. MDP version is okay. But when it comes to silane, you don't want to use that. Okay? Another one, you have a kind of like a Emacs, and then they follow the protocol. Like this one, interface A and B has organic acid, so it has acid, right? Like MDP is organic acid too. It's their own secret, but they say organic acid and silane, so they're actually kind of together. Monobond Plus has silane and MDP in it together. And I think this Ivoclar clear, what is it? It's still monobond, etchant prime. They have silane and another kind of etchant. And then this is from Optibond. Actually, no, I'm getting over my eyes. Okay, anyway, so only pure silane is this one, okay? Pure silane is that one. And they did the shear bond test, like kind of like that, but with a better equipment. So only the pure silane worked. All the other didn't work. Again, this is polished surface, okay? So when it comes to chemical bonding, the silane is important, but silane cannot be activated with MDP, any acidic environment. It gets activated, but then if you leave it too long, they kill each other literally. They bind and become inactive. Okay? So when you are choosing, and then this is a surface test for ceramics. So you typically measure the contact angle. I think I kind of briefly talked about that before. But if if it's hydrophilic, the water disperses well because the surface is high energy. They have energy to disperse the water molecule. But in here, they don't, so it's kind of water droplet. Okay? So if you have pure silane, okay, I told you pure silane is another rule is to make it hydrophobic, right? So this is the test that you can see. MDP has silane in it. The Scotch bond has MDP and silane. So we're looking at pure the contact angle, okay? Both put different one and then kind of disperse onto it. Look at, so this one was able to create hydrophobic. This one can't, right? So when the silane is with MDP, their function is abolished. Okay, so when you choose, okay. Now why do you even bother about this chemical bonding? Okay. Because micromechanical bonding itself does a good job, actually. So that's why many dentists they do bonding and it doesn't fail immediately. Because, yes.
I thought you want hydrophilic.
Now, you want to hydrophobic because resin cements are all hydrophobic. In order for resin cement to bind onto it, you need to make the surface hydrophobic. It becomes hydrophilic when you make it rough. Rough surface, like a concrete rough, right? You put water, they just get dispersed, right?
It bonds better, right? You said it's hydrophilic, it's more rough, so it bonds better.
Yeah, so that's the problem. We created microporosity, right, to increase this micromechanical binding, right? But that surface is not ready for hydrophobic binding. That's why we are adding this primer and adhesives. If you can just do it, why do we use adhesives? Why do we even use prime and bond? We just etch it and put the composite. But it doesn't work because composite is hydrophobic and etched surface hydrophilic. They have a high energy on the surface. Whatever it binds, water disperses, but they are not ready to take this hydrophobic materials. So after we make the any time you make the surface rough, it becomes hydrophilic. And you have to do something to make hydrophobic. And to surface, that's why we put primers and all that stuff. In this glass ceramic, we put the silane. And by putting silane, as you see, it becomes hydrophobic.
So composite and resin cement is hydrophobic.
Yeah, because they have a BCMA, all that is just, they just have a long carbon chain. It's very, it's like a hydrophobic, right? And they only have 2 arms, they can polymerize. That's why composite can never make it shrinkage gone. It always shrink composite because they polymerize. By polymerizing it, they pull them each other together, so they get shorter and they get shrink. And that's what it is.
Doctor, basically, feldspathic porcelain have the hydrophilic surface.
Yes, yes, yes.
But fluoride acid can make the higher hydrophilic surface, making the hydroxyl group.
Yeah.
Yeah. So because we can adapt more easily using the silicon coupling agent.
Yeah, that's, yeah.
Hydrophilic group.
Yeah, so, yeah.
Yeah, so fluoride treatment is enhance the hydrophilic surface to enhance the reaction of the silicon coupling agent.
Yes.
Yes, right?
Yeah, you're exactly right, exactly. That's why the silica, if you look at the chemistry, one arm is hydrophilic.
Right.
Yeah, one arm is hydrophilic, totally. So it's kind of like a hema-like component. Yeah, so it binds well to the surface.
I feel like some people might be getting confused because we have to kind of bond. It's like the first question when you're asking me which surface to bond to what, because we have a cement layer, we have a bonding layer, and then we have the tooth structure, and then we have the restoration structure. So everything has a different hydrophilic to hydrophobic to hydrophobic to hydrophilic. So in that process, we get confused. Because
No,
I thought that
yeah.
silane was actually helping, but now you show me
No, silane is helping.
No, but the combination of the bonding agent
And MDP.
Yeah, that's the
Yeah.
They are just confusing us with that.
So when company sells a product that we have this thing that has MDP and silane together, that's the issue. I'm
I thought
not.
that was helping, but it looks like.
Yeah, I'm not saying this MDP is not good, silane is not good. They're good, but when they're together, yeah, MDP is still good, but silane is not effective because MDP itself is acidic. You're putting silane in an acidic environment.
So MDP and silicon coupling agent have the different reaction mechanism.
Yes.
So everybody confused now. So why the company confused the together, the MDP and
Because they claim that it's going to make it better, faster. Yeah.
so MDP is based on the phosphoric acid monomer. So it inhibits the silicon coupling reactions.
NDP is what?
MDP is based on the phosphoric acid.
Uh-huh.
Phosphoric acid.
Yeah.
So that they can inhibit the reaction of silicon coupling agent.
Yeah.
Yeah. So I know the first time many products confusing together MDP and
Yeah.
silicon coupling agent. So it's very confused.
It is. That's what I'm trying. That's exactly why I'm here, to saying. So, when it comes to putting the silane onto the glass ceramics, stay with the pure silane. That's what I'm trying to say. Okay. I mean, this product is great for zirconia bonding. And zirconia bonding doesn't need silane. You can still use it. Now, I know if you use this to bond on the glass ceramic, it works too. You know why? Because the micromechanical bonding helps a lot. Okay? So it won't fall out. But if you look at this, no, let me, I should put that one in.
Doctor, in Korea, the monobone can use either feldspathic porcelain and zirconia. So to use everything, they combine MDP and silicon coupling agent.
No, but then if you do the testing with a polished surface, you will see the big difference. Okay, we can talk. We can talk later. So this is the thing. Like, oh no, not. Oh, maybe I'm missing the slide. Oh, here. So the reason why you need the chemical bonding is, imagine over a long period of time, there's a crack here, okay? If there's a crack here and there's no chemical bonding, it's going to dissociate because no interlocking system. And it will crack over time because all the stress, the teeth are under stress, right? But if they're chemically bonded, all surfaces, it's going to stay, right? So whenever possible, you want to maximize the chemical bonding, okay? Yeah, I think I missed that. So here's another. So recently, the Panavia came out with lithium silicate, long chain silane with MDP, and they say they actually combine that, and they say that this is true universal. Okay, and in fact, there's the Ve Mierbik lab actually published the paper that it works. Okay. So they also use a cemented onto polished surfaces, and long chain silane, whether you like cured, chemical cured, they worked. And this is different one, Panavia CA that does not have silane. If it's like cured, obviously it doesn't work because there's no self-fill capacity. But if you put the clear fill ceramic primer, which is the silane, it binds better. Okay? So they claim that this long chain silane is compatible with MDP. Okay? But what they actually use is lucite-based IPS impress. Okay? And this is something we're working on it right now, but it doesn't work all the time with different glass ceramics, for example, Emax. Okay? And we don't know why. We're trying to find the reason, but if we do exactly the same thing on the if we do the lucite-based material, we can duplicate the data. But if we do it in the Emax surface, it doesn't. So it's kind of puzzling, but the chemistry itself it tells us that MDP and silane, they really don't go well together. All right, in the UCLA, a little more into the clinically, we have some established the bonding kind of thing. I don't have any conflict of interest with BISCO, but then BISCO has been long fan of UCLA collaborator partner. So we use the BISCO dual link. And I'm more than happy to share. I'm not going to go into details, but pretty much these talks about kind of together. We use a pure silane. And veneers is another thing. We're going to briefly touch about the veneer too, but then very much similar. Some cases like this is exactly what I meant. It's kind of over-etched. You see this like little salt over-etched. I'm sorry, not over-reached, over-etched area. So I did 37 phosphoric acid with a vigorous brushing, and it got a little bit better. I put the silane, and then it can deliver. And I used a selective etch technique, okay, and then Alba universal kind of a couple times. And then the good thing about using like dual link is that you don't have to remove, right? You just leave it until it's partially solidified, so you can flick it out, and then give full cure. Okay. So whenever you use dual link or dual cure, don't waste your time cleaning up from the beginning. It's kind of like a light cure cement where you tack cure and then you can flick it out, right? So wait like a couple minutes and you can kind of take it out and then you can do it. Okay, zirconia. Let's go into zirconia. I know we have a zirconia expert here, so and two zirconia experts. So hopefully I don't make any mistakes. Zirconium is a metal. Zirconia is a zirconium oxide, and that's where ceramics. Okay, so if you take an X-ray, it's like metal, like thing because they are derived from metal. So zirconia have a polymorphism. They have different kind of configurations. In room temperature, they are in the monoclinic, and it's kind of very disorganized. If you bring the temperature up to about 1500, it becomes very organized. We call the tetragonal state, right? If it's even higher, it becomes cubic, okay, and it becomes more dense. But if you're like lower the temperature, it expands. Okay. But if you add yttrium, okay, 3 to 5, either 2 to 5%, okay, it will. When it comes back to room temperature, it will maintain the tetragonal state. That's why it's really hard and solid. Okay, and that's why we call the yttria stabilized tetragonal zirconia polycrystal. Okay, so that's literally what it means. You add this, and instead of going back to monoclinic, it will maintain the tetragonal state. Okay. Now, problem with the zirconia is aging process. What it means is the transformation of tetragonal to monoclinic in room temperature when there's water. Okay, and how does that happen? When there's a kind of micro cracking, that's where it kind of starts. So water penetrates in there, and then the transform zone kind of expands, and then it transforms to monoclinic state. Okay, this is why we don't want to like grind and make a rough surface on this zirconia. And there are different contributing factors for this, and those are the contributing factors. So basically, the characteristic of a zirconia is they're acid resistant. Okay, they don't get etched, and they don't have silica. Okay, they're very dense, and any alteration in zirconia surface may initiate this aging process. So that's why you don't want to make a rough surface. You need to have a really nice and polished surface in zirconia. So what does that mean? That means we cannot use hydrofluoric acid. Although they are etchable, but with very strong acid, but not hydrofluoric acid. Silica is free, so cannot use silane to the zirconia. Okay? And you have surface roughening. Because of that, I think there's a debate whether we have to, how much of the surface we need to roughen, right? So the bottom line is the conventional way of bonding glass ceramic does not work with zirconia. That's why in zirconia crown over here it pops out, right? Anybody have experienced that? You deliver zirconia and it came off, okay? Because all this conventional way of delivering it won't make a bonding. Okay? So for zirconia prep, it is important your macro retentive feature is important, like axial wall. Okay? So we're going to talk about those. Okay. So surface roughening, if you really roughen the surface, and then look at the flexural strength. Flexural strength is like like a kind of 3 bending test. You press it down, and when it breaks. So the polish, if it's polished surface, it's about 1,200. But if you grind it, okay, you see the significant decrease because that's where the cracks kind of initiates, right? But if you polished, you sandblast it. So you sandblast with the 120 micron aluminum oxide. It also creates some crack, so it decreases the flexural strength. But if you use about 50 micron, it's okay. So that's why whenever we talk about zirconia, avoid grinding, like especially integrity of the crown. and avoid sandblasting with large size particle, okay? Because it will create this aging process. So best thing is about use 50 micron to roughen the integral surface. So when you do sandblasting, it's really important that it follows the specific protocol, because if not, then it really deviates from this good quality like texture of zirconia. So use aluminum oxide. Pressure is about 2 to 3 bar. Uses 50 micron. 20 seconds in 1 to 2 centimeter. So if you look at low power, you cannot even see. So if that happens and you look at the crown, there's no change. You don't notice the change. But if you look at the high level, there's a surface kind of sandblasted. Okay. So there's other ways to increase this zirconia bonding. Okay. And currently there's things like a Zurad or Biomix lithium silicate connect. So what you do is you apply that integrity of the crown after milling, but before sintering, okay, before baking. So like for example, like Zurad, you kind of mix this solution, you paint it on. It's kind of dark, so it's kind of good if it's dark because you know where you're painting, right? So once you paint it and sintering, it's gone. And the color is because of the carbon that's in there. When you bake it, when you're sintering it, it goes away. So it comes back to this normal state. So what it creates is that it really roughens the surface pretty well. And they're chemically bonded onto the surface. So if you look at the hydrofluoric, this is hydrofluoric acid, by the way. You don't see the change, all right? So this one, this Zurad, it's like a slurry of the zirconium particles, right? And I know Dr. Ho knows better because he invented it. so I'm speaking of this in front of the expert. But anyway, so Zurad will create this roughened surface, really increase the roughening of the surface. And there's a paper, and there's another zirconia expert here who probably he's right there. He's a PI on this paper. We actually compare no treatments and blasting and kind of toxic acid and Zurad. And literally Zurad is pretty good the retentive feature. Okay. So you and I mean nowadays I think people are getting more the lithium Biomix lithium silicate the other one, that's more like a lithium silicate particle. So you can they claim that it's etchable surface. Okay, so you can use that. I never use that one. So the take-home message here is you really have to communicate with your lab. Okay, you can't do this by yourself. You can't do this in your lab unless you have an oven, right? You can maybe do the sandblasting if you have equipment, but talk to the lab. Write down your prescription pad, or see if your lab is actually doing this, or if they actually know this. Right? You can educate them. They think you're like smart, and like, right?
Doctor, we actually start using more and more zirconia for a lot of reasons.
Yeah.
But one of the concerns is because the zirconia is so stiff and so hard, so actually that's the reason why we use it. But the problem is also the tear and wear speed of zirconia compared to other structure of tooth and different kind of restoration.
Yeah.
I don't know that harmony in long term, how good or bad is going to be like stabilizing or keeping the bite in the correct position or any of this kind of deteriorating other restoration.
Yeah, we have two experts who can chime in, but my understanding is more like the smooth surface of the crown that really matters, and how you design your occlusal scheme. Okay? If you can come up with a good design of the occlusal scheme and polish it well, porcelain, if it's kind of grainy, it really like grinds opposing teeth. When it's real polished, it doesn't. So I think it's more about, to me, I mean, there's always, of course, that's a factor, but then an additional half of the problem is from your how you practice, how much you know about the occlusal scheme and contact and bite, you know. So I think it's very, very multifactorial thing about that. But if you want to chime in, yeah, no, okay, all right. So again, good communication. That's more. Okay, so let's kind of discuss about NDP, chemistry of NDP. So MDP and zirconia, NDP has a phosphate group, right? And their bonding is not condensation, it's just the ionic bonding, right? But they also have hydrogen bonding. And this paper published in Scientific Report saying that if they have only hydrogen bonding or ionic bonding, it's weak, but then the bonding, if they're combined, is increased. The bonding capacity is increased. So they said that's how it works. So going back to our silane stuff, zirconia binds to MDP, and then resin semi-soft is hydrophobic, and they do have both the polymerizable the side chain, and then that's how they all link together as a chemical bonding. Okay. So now the problem is the phosphate group in MDP, it exists everywhere, right? Oh gosh, see, this is the problem with animated slide. Once I come back, I have to go through everything. Okay, so in saliva we have phosphate. Okay, and phosphoric acid that we use, 37%, is also part of that. So if you use them on zirconia surface before you put the kind of MDP mediated primers, it's going to prevent from NDP to bind there. So if you use this, if you do the trying all that and then try to do it, you lost your chemistry there. So what you need to do is don't use phosphoric acid on zirconia surface at all. Okay. There's no reason why you need that one there. And if you have saliva or even phosphoric acid contamination, use Zirclean or Ivoclar, the Z-Clean. They're nothing more than alkaline solution. So in alkaline solution, they release this bonding, okay? And they use zirconia primers that contains MDP. Now, I mean, I don't care about silane and zirconia, so feel free to use them. Yeah. So for zirconia, I know a lot of you guys do zirconia crown. I do zirconia crown a lot too. So when do I know what to use, right? So when retention is sufficient, you can just use the RMGI, okay? Because the retention itself will, the macro mechanical retention itself will hold the crown. Okay? If the prep is compromised, you can kind of use self-adhesive. And when it's severely absent, like veneer, if you are bold enough to do zirconia veneer, then you can use adhesive bonding. Okay. Now, so when can I deliver the zirconia? Okay. So if you have about 8 to 10 degree tapered, okay, then you have really good enough retention. And your axial height is about 3 to 4 millimeter, then I think you're safe to do zirconia. Now, I like to draw your specific attention to buccolingual, because kind of furrow effect happens on buccolingually. It doesn't really happen medial distally, because medial distally there's a teeth preventing it, right? So it doesn't really rock unless you have no teeth. So important thing is buccolingual rotation, right? So if you have a good kind of furrow effect, even though you have a really tapered, for example, you have to have this kind of prep, but if you have a good retention, the bottom third typically it holds very well. Yes?
Sometimes I heard about that make the notch for the buccal area because the increase the retention, but the other people said that it's better to place a notch on the distal medial.
Yeah. So if you look at it, it rotates buccolingually. It rarely rotates mesial distally because the teeth are preventing it from it, right? And we're grinding left and right. Not really like this, right? So putting the retentive feature buccolingually is kind of useless. It's better to put in distal, mesial distally, because that retentive feature prevents from walking, right? So if you put buccolingual, I wouldn't do it. Yeah, I try to make the 1/3 of the prep more like straight. That gives you very strong. So typically, when the crown comes to me, I try to rock it buccolingually, and if I have a good retention, and I feel safe. Yeah, but like so a lot of times it just come out, then you don't really have much macromechanical retention. Then you may want to consider bonding cement and like that. All right. So for UCLA in our clinic, we have this bonding protocol. We have established this, and I think it works pretty well. Well, this is one case. I'm bold enough, obviously, to do online with zirconia. So I kind of put the zirconia there. You know, it just like looks plastic. It's like, dang, you know. And then you put the Z prime. I tried it, and then I actually cleaned it with Zirclean, and then put the Z prime. And then selective etch, right? This time, typically when you etch and bond it, you kind of have to protect the adjacent teeth from binding. Otherwise, you're going to spend like 30 minutes removing the cement there, and then rinse and Albanu everywhere, including the dentin. Here, I only put in the enamel and cement it. And then I typically, when I do the margin, I actually use composite polishing. I don't use dialite. Because if you really think about it, what are you trying to do here? Your margin should be fit well. What's the point of using dialite? If you use dialite, it actually remove your composite, it may remove composite cement, and you see the line. So if I were to have some opening, right, I'd rather have the composite and fill it up. And polishing with the composite polishing is good enough. Will give very nice margin. All right, so I think this is the last one. Okay, we're okay this time. Okay, so some of the issues with the universal adhesive and dual cure cement. I think this is something that you need to understand. You don't really have to understand this if you use dual cure cement that has amine-free. Have you heard about amine-free cement? Yeah? Okay. So let's talk about that. Okay, so now we have to go a little bit more into chemistry. So light cure, they're solidified the photo initiator, right? Of course. And then self-cure solidified the self-activator. And then the camphoraquinone binds to this aliphatic tertiary amine molecule. It's a linear. And then creates a free radical, and that's where the polymerization activation starts, reaction starts. Now, for self-activator, the BPO combined with aromatic, circular, right? Aromatic tertiary amine ring, and then it creates the free radical and it starts. Okay, so they kind of use different mechanism. And dual cure, literally, they put them all together. Okay, so if you leave long enough, they'll cure by themselves. If you wanted to just quickly cure it because you're afraid of blood contamination or whatever, you can activate it quickly and then let it go. Although I don't like that way. So, but then this is a problematic. Aromatic tertiary amine that's the one that causes problem. Let's take a look at a little bit more why. Now, this one does not get activated in acidic condition. Now, here's another thing that cannot activate in acidic condition, right? So they're not compatible with universal adhesives. Okay. So when you have the tooth there, you put a universal adhesive, And then at the end of it, I always have oxygen inhibit layer, right? And in there, you're gonna have free like MDP and water, a little bit of molecule sitting on the top, right? And then on top of that, you're gonna put this this dual cure cement. Now I mentioned before, dual cure cement is a self activator and creates a free radical, and then start polymerize. But this, the acidic condition inhibits this, so that's why it doesn't get activated. So actually, I mean, this is kind of well known. It's from old study. I mean, if you use the edge, so we edge for 15 seconds, apply each adhesive, okay, chemical cure, light cure, and then we evaluate it. Anytime we have a chemical cure, they don't form. They don't get the good bonding strength because they don't polymerize. Okay? So there's incompatibility between acidic universals and this this aromatic tertiary ring. Okay. Another one is that it causes discoloration over time. Okay. I should give the credit this to Dr. So, and because it's not my slide, I'll tell you from the beginning. 12 years later, the A1 become A4. Right? And this one was cemented with a dual cure cement. Okay? Well, that has aromatic tertiary amine ring. Okay? So what's the solution? The company, they know it's a high pH. Visco is a low pH, but I'm sorry, not high pH, low pH. Now Visco has low pH already to self-etch and all that, but high enough to not prevent this inhibition of the reaction. But others, they're too low. They inactivate the self-cure mechanism. So what they come out with is other self-cure activator. They're literally self-cure contain sodium benzene sulfate, which generates free radical in acidic conditions. So by putting those two, mixing those two together, you're actually the acidic environment. They get activated under acidic environment. Okay, so they're kind of making this free radical for this self cure. So you're at the level of adhesive. You're trying to take care of it. Now we don't want to do that. You see, there's another bottle, another step. Like no one wants to do additional step in dentistry, right? So they come up with replacing that with amine-free. So if you go website and search any universal, they always claim amine-free. Okay? So that's what it means. Okay? We don't have amine, so don't worry about this. Okay? So self-cured is not influenced by acidic adhesives. So like RelyX ARC, multi-link speed, they all have self-cure. Okay? The aromatic tertiary amine, but all these the kind of latest cements, they're amine-free. Okay? So take home message. If you have been practiced 20 years and you haven't changed your materials, maybe it's a good time to change. Right? Because if you're using new universal and use old this system, it's not going to work. Okay? So do check your inventory and make yourself up to date with current materials. Okay? When in doubt, so look for amine-free. Is it amine-free? Okay? I think that's about it. But I feel like bonding is like social bonding in society. Right? You gotta get to know the material, otherwise you're gonna get left out, and your patients keep complaining. In the clinic, a lot of students have a patient with the sensitivity after composite restoration. But to be honest, I rarely have that issue. I'm not saying I'm good, but I follow the protocol, right? And to be honest, I place rubber dam when I do composite. I'm kind of like a very kind of textbook style. So when it comes to this restoration, people like students, they hate rubber dam. It takes 30 minutes, but literally it only takes 5 minutes to put good rubber dam. But I understand what they're going through, and they start using isolite. But even isolite, a patient breathe in and out. They breathe and create moisture, right? So I tell them to put the cotton 2 by 2 to prevent from this moisture, right? But if you don't follow this the protocol, I mean, the blame is on you, right? And your assistant cure 10 seconds and it's sensitive, blame is on you, right? You're the one who needs to get blamed. So get to know your material. Don't be left out, okay? Be compatible to each other. I think that's an important thing for in dentistry. Okay, thank you. And UCLA Research Continuum is coming in 2024. We're planning on this. We have 3D printing, milling, all in-house. We're making this curriculum to go from A to Z, all right? Including this. We're trying to expand this with bonding to lithium disilicate or kind of like that, even zirconia. So if you feel it, if you experience it, then you will trust. I'm actually born as a researcher. I got my PhD. I don't really trust until I experience it. And that's the very reason why I brought this. If you have time, go ahead and experience yourself and trust yourself. All right? So, yeah, thank you. And I'll see you hopefully next year in UCLA. All right. I can entertain any question if you have. Yeah.
I have a quick question regarding actually light curing. So I use Velo, and then there's 3 different types of mode for the Velo. One is like you can just regularly use for 20 seconds. The other mode is that I think it increases the power and shorten the amount of time. But so my question is that when you curing, is it all about the energy that you're transferring to cause the free radical reaction?
Yeah.
Or
That's a good question. I actually was going to put that slide. If you cure like bulk fill, there's actually the video, you can see it's because the polymerization occurs toward the light, right? So you can see the bottom is lifting up. So I don't like fast curing. Only way I like to do fast cure is when I try to modify the provisional margin, add the light cure, the flowable, and I don't have time for wait like 40 seconds, so I use a fast cure. But if you put huge energy all at once, they contract too fast. So when you do light cure, just go with the regular speed. Okay, you want to let them polymerize like eventually, progressively. You don't want to polymerize at the top, and the bottom will kind of contract all of a sudden, and you're going to have a leakage. Okay, so I don't like to use that. I can kind of, if you guys are okay. This is a lecture slide. Just a few things I actually wanted to put this one in today's lecture, but I didn't have time. Okay, so basically, it's actually the energy that kind of generates a free radical, right? And then initiates. And they all have a certain energy required to fully polymerize. If you look at your label for composite, they all have it, okay? And just going, let me see. The important thing is the distance is very important, okay? And if it's too deep, just do longer, 60 seconds. Do you think if it's getting hot, just rest for 10 seconds and do it again. So if you're planning to put composite deep in the class 2 really deep, that is like really deep. So like cure twice as much. You're delivering the energy twice as much. Okay? You always have to think about how much of the energy you're transferring. So, okay, this is what I wanted to kind of share. I think this is very interesting. we used to have this mark system. Somebody stole the computer, so we don't have anymore. But fortunately, I took the pictures, so I still lecture with this. So this is irradiance, and the area under the curve is the power. That's a power generated. Okay. So irradiance is how much this light curve generates. The longer you do, more energy gets transferred. Okay. So if you do free hands, like you don't do the fulcrum, and then you go like this, that's what you see. Because we shake our hands. Okay? So you always rest onto somewhere when you do it. Now, start moving away from the tooth. So if I go like this, and then I start moving away, and it drops like crazy. I came back to the tooth, and then start tilting it. Okay, and how the energy is going down. So when you cure it, you gotta look. That's why you see this orange shield, right? And this is like this is I see sometimes my assistant put this on and trying to find the next tool for me. I'm like, don't do that. That's exactly what's happening. If you don't look at it, it goes everywhere. So if your assistant is doing light curing, they're messing you up. They're messing up your beautiful, nice composite restoration by not fully curing them. Okay? So you have to train your assistant to do the right thing. Okay? You did all this nice anatomy, you packed it, make sure you didn't go more than 2 millimeters and like perfect, but if they don't cure it right, it's bad. Okay? So yeah, it's you. Anyways, yeah, that's a curing thing. So yeah, back to your question. Refrain from using facet. Yeah, I don't like to use that. Okay. Any questions? Hungry? Let's go eat. And we have a next session. We have Dr. Hall. All right. Thank you.